And also, if you get questions from us, you will get from the
then I can put that in and maybe avoid questions later. So that would be nice.
Não precisa de te ouvir todos. Não tem que ser melhor totalmente. Não está de brincadeira. Eu vou ter a outra pergunta. Vai. Deixa eu ver se a última que eu sou segura, cara. Não tá indo. É a gente vai selecionar.
I thought you walked in, but I wasn't sure which slide it was. I'm on the third page, so it's like my pager and
yeah, I saw you one of your reports yesterday when I was trying to get the question.
yeah. Yeah.
Well, I just coming today for someone. Normally,
It's so much harder, right? Because you kind of just come in and then you're get caught up, and then by the time you get caught up, it's
but I think it's good, like, when you say a lot. When you think you forget what's what kind of thing. I'm like, oh,
yeah.
And it's not just like seeing the basic video. Sometimes it helps, I think, if someone's not been involved at all. It's like, hopefully it's helpful.
No, it's just it's meaningful, you know, because I want to be able to send measures in a year. It sort of came out of the presentation. I think success at the end of the year.
No,
Technology, not sure which grade I'm supposed to be using.
You're a radiologist, you're used to having like
and also having a lot of technical difficulties with those. Actually, like those renovations are happening at my place.
Oh,
the stage one was before, and the stage two is now. So it's like a disaster right now.
Very much.
Yeah. Oh yeah. She didn't get back to us on
No,
that.
Jennifer now, but Jennifer needs.
These like crazy spiders, and then like switch them out of the attic.
Yeah, well, we can not that.
Is she actually
I know wrong. I feel like you did. Yeah.
The problem is the spiders have been wrong. Real spiders are you got the.
Yeah, I bought a book.
Like other ones that like no,
Right? It's like there's more layers in your brain.
Around the brain.
I can
You don't have to.
for certain.
Oh, I will.
Good afternoon, everybody, and welcome to ClinEpi Rounds. Is this getting close to the last one of the year?
Two more.
Two more. Okay, then you don't have that honor. Somebody will. So today we have Sapna Rawal.
Yep.
Yes. Okay.
Impressive.
Thank you. Who's a diagnostic neuroradiologist at JDMI, which is the Joint Department of Medical Imaging at UHN, Mount Sinai Women's College Hospital. She's also a PhD candidate in ClinEpi, and Andreas Laupacis is supervising her. She's going to talk to us today about, as you can see, the impact of timing of aneurysm treatment on clinical outcomes in subarachnoid hemorrhage. And the work she's going to talk about today is part of her PhD. It's all going to be part of her PhD.
Sorry, guys, you're going to have to hear all of it.
But this isn't a formal PhD defense,
No.
So you want to take questions as we go along, or at the end?
I'd really like that, actually. For me, this is sort of, I'm coming to the end of it. I'm in the process of writing it up, so this is coming at the perfect time for me, where I can get some serious, hard-hitting feedback from you guys and hopefully incorporate that in to not have to deal with it later down the line when I'm actually defending. So,
Okay, thanks.
Yeah,
Okay.
super. Thank you so much. And so thank you very much for the opportunity to present here. This is obviously going to be really useful for me. I hope it's going to be interesting for you. Unfortunately, I don't get to make it out to these rounds at all, really, because I'm always on clinical service on Fridays. I always do the second half of the week. So we'll try to switch that up in future. Once I have my PhD, maybe I'll have more power to sort of control my schedule. So as George said, my PhD is about the impact of timing of aneurysm treatment in subarachnoid hemorrhage. And so the learning objectives that were sent out to you guys, basically, we do have a significant knowledge gap on when the optimal timing is to treat these patients. And so I'm going to give a little bit of background around that, and then also discuss the steps I took to try to answer these questions. So firstly, a systematic review and meta-analysis of the existing literature, and then an ISIS-based cohort study addressing that topic. So just a brief outline before we get going. So a bit of background on the disease itself and what we know about the status of timing in the literature, going into my research question, then I'll get into the studies and kind of conclude with some interpretations and limitations of what I've come up with. So subarachnoid hemorrhage is most commonly secondary to aneurysm rupture when it's non-traumatic. It's a fairly rare disease, but it is a disease that is associated with a high morbidity in survivors and a high mortality as well. So a lot of effort is put into trying to optimize outcomes in these patients. And the major principle of management is promptly identifying and treating the aneurysm. And I put that in quotations because, as you'll see, we don't really have a very good definition of what prompt means. In the literature, we know that the major predictors of outcome are age, so increasing age is worse for these patients, and also disease severity in terms of their neurologic status on presentation, and the volume of hemorrhage, which is classically determined on CT. So just to summarize a little bit about the treatment, there's two major ways that these patients are treated. Commonly surgical treatment, which is referred to as clipping, and versus endovascular management, which is referred to as coiling. Essentially, surgical management is obviously more invasive because you have to perform a craniotomy, go from the outside, sort of, pull back the brain, get to the aneurysm, and then put a clip across the neck of the aneurysm that's ruptured, versus endovascular treatment, which is done by my interventional neuroradiology colleagues, which is less invasive. What's done is the access is through the femoral artery in the groin, threading a catheter up into the aorta, up into the intracranial circulation, and then packing the inside of the aneurysm with these coils, which are thrombogenic. And so that sort of occludes the aneurysm. Choice of treatment is essentially a case-by-case decision. The major determinants of that are essentially where the aneurysm is located, if it's amenable to one or the other treatment, and also the morphology of the aneurysm. In a situation where there's clinical equivalence, so essentially either treatment could be performed, we know from RCTs that coiling is superior. But that's in fact the minority of patients, which we know from the kinds of patients that were randomized into these trials. It was usually quite a small subset of the patients that presented. So why treat these patients promptly? The major issue that can arise, and is most likely to arise in the immediate post-subarachnoid hemorrhage period, is rebleeding of the aneurysm that is unprotected. So That's obviously not a good thing. It can occur in up to 20% of patients, and it can have devastating effects on outcome. Up to 70% of those patients can actually then subsequently die related to that increased volume of hemorrhage. However, in our current sort of standard of care practice guidelines, treatment is recommended to occur, as I mentioned, promptly, and generally that's interpreted as within 72 hours. So that doesn't really match up with what we know about this concept of rebleeding and when it's most likely to occur. On the other hand, why not treat promptly? That's more of a resource accessibility issue. If patients are coming in sort of in the off regular working hours situation, having access to an on-call interventional neuroradiologist or surgeon is fairly limited. It depends where the patient presents. It's also relatively costly because it's not just the surgeon, it's all the support staff, et cetera, that has to be in place for this to occur. And at least from the interventional neuroradiology perspective, there's been a lot of emerging evidence now that stroke is extremely time dependent, and interventional neuroradiology is very implicated in actually going in and removing clots from the intracranial arteries. So our interventional neuroradiology services are quite taxed in terms of dealing with that. The other factor is if you have the ability to not treat these patients in a very time-sensitive way, you can actually transfer the patients to a higher volume center. And we know that there is a sort of volume outcome relationship when it comes to most procedures. So those are all issues that might go against treating these patients very urgently. In terms of when I was putting this together, what was the status of evidence for timing of treatment? For clipping, there had been a prior meta-analysis that was performed in 2002, which showed that outcomes were better if these patients were treated early or in the intermediate phase, so anywhere from day 0 to day 7 post-event. So it's not really very specific. Whereas for coiling, there hadn't been any meta-analysis done, there hadn't been any RCTs done. And just going through the literature, I felt, and I think a lot of people felt, that there was a lot of conflicting evidence regarding the results of these studies that had addressed treatment timing. So some said there was a benefit, some said maybe not so much. But a lot of these studies were small because, as I mentioned, it is a rare disease. And if it's a single center study and they don't have necessarily a very big catchment area, they may not be seeing a lot of these patients, issues with loss to follow-up, et cetera. So the quality of evidence didn't seem to be so great.
A question?
Yeah.
Can you go back to the previous slide? So the meta-analysis in 2 improved outcomes compared to what?
Treating late, treating beyond 7 days.
Oh, late. Okay.
Yeah.
So it's just the timing of the intervention. It's always clipping.
Yeah.
Okay.
So just to kind of put that then, summarizing it into my research question, we know that there is this negative effect of aneurysm rebleeding and that it's most likely to occur in the early post-subarachnoid hemorrhage phase. So that would lead us to think that there would be a benefit of treating these patients earlier, but didn't seem to be necessarily borne out in the literature. It didn't seem to be incorporated into practice guidelines. And having this information would be really helpful to actually inform these guidelines and also to determine resource allocation. So I decided to start by performing a systematic review and meta-analysis of the literature specifically for timing of coiling. I focused on that because there had already been a previous meta-analysis for clipping, and there hadn't been a lot of new evidence after that fact. The sources of data that I used were observational studies because there were no RCTs on this topic, and I performed a very broad search with the help of a medical librarian. And the studies that I was interested in including were studies that addressed any population with proven subarachnoid hemorrhage where the subjects underwent coiling, where early versus late treatment was compared. At this point in time, I wasn't specific about the definition of early treatment. I kind of just wanted to capture everything. And the outcomes that I was looking at were poor functional status, defined by commonly used grading scales for neurologic status, specifically the modified Rankin scale and the Glasgow outcome scale, which are typically used for post-subarachnoid hemorrhage outcomes. And the secondary outcome that I was looking at was mortality. Measures of treatment effect that I was looking for were crude and adjusted odds ratios with their associated confidence intervals. I used random effects forest plots to synthesize the data to account for both within study variance as well as between study heterogeneity. I assessed heterogeneity kind of via the standard methods, Cochrane's chi-square test, as well as the I-squared index, using a conservative threshold to declare heterogeneity. And for assessment of risk of bias, I used the Newcastle Ottawa scale for cohort studies. And so in terms of dealing with the heterogeneity, I had been thinking that if I had enough studies, I would use meta-regression, but I didn't end up having enough studies, so the plan B was subgroup stratification, and that's what I ended up having to do. And the subgroups were defined a priori based on the factor that I felt was most likely to introduce heterogeneity, which was how early treatment was. So I had set up a number of subgroups in my plan, which is essentially if early was defined as within 1 day, within 2 days, or within 3 days. If early was defined as beyond 3 days, I didn't bother including them in the data synthesis because what I was concerned about was sort of the clinical relevance or the clinical question of is it worthwhile to treat these patients even earlier than the current standard of care, which is within 72 hours. And then I performed sensitivity analyses to assess if my results were robust by excluding studies that I felt were at higher risk of bias, because as I mentioned, that was one of my concerns going in, was that a lot of the studies might be smaller, might have lots of follow-up, et cetera. And so in order to do that, I used the Newcastle Ottawa scale grading that I had, and I limited the forest plots to studies that performed well on that. Also, specifically studies that had an equal distribution of poor grade subarachnoid hemorrhage between the timing groups, and studies that were initiated later after the randomized control trial that showed that coiling was in fact superior to clipping where there was clinical equivalence. And the reason for that was prior to 2002, coiling was kind of like an emerging technology, and a lot of surgeons didn't really trust it. And so it was sort of felt to be reserved for patients who were poor candidates for surgery or those that weren't going to do well. And I didn't want that influencing my results too significantly. So in terms of the results, so going through the abstracts, I whittled it down from 834 that were initially identified down to 16 studies that I eventually included because they satisfied my PICO criteria. And this is, sorry, a busy slide, but I kind of just wanted to show that there's a very wide range in the numbers of patients included in the studies. So smallest is 45, largest is 1,084, so very broad. And overall, in most cases, the populations of the studies address sort of the typical subarachnoid hemorrhage population where the classic age is anywhere between 50 and 60. It's usually majority female patients that suffer from this. Most of the patients that come through the door are good grade, so they have better neurologic status. And most of the aneurysms that are the culprit aneurysms tend to be anterior circulation. So that's what we did see, except for in certain studies where they were specifically trying to address older populations or specifically poorer grade patients, et cetera. Okay, so forest plots. So these are the crude odds ratios, starting with the first, or my primary outcome, which is poor functional status. And these are stratified into the subgroups based on how early is defined. For the top here, the subgroup where early was defined as within 1 day, I actually had a number of studies that only defined late treatment as occurring from day 1 to day 3. So I was able to create a separate subgroup for that. And then in the second subgroup, we see early treatment within 1 day compared to late treatment at any time beyond 1 day. And that was the only one that looked to be statistically significant, where early treatment was defined as within 2 days compared to beyond, or within 3 days compared to beyond. I didn't see any impact of treatment timing. So just zooming that in a little bit, the significant subgroup, it seemed as though there was a benefit of early treatment within 1 day compared to treatment beyond, and with an odds ratio of 0.4 and 0% heterogeneity, essentially with the I-squared index. And then performing sensitivity analysis, removing studies that I felt to be at risk of bias. It did cut out a couple of the studies for sure, so it brought me down to 2 studies with only 141 patients, but the results were consistent. So that was encouraging, even though I'm still working with a pretty small number of patients or studies synthesized at this point. So I was encouraged by that, but then when I looked at the adjusted analyses, which were only reported in 3 studies, where early treatment is defined as within 1 day, the results were sort of all over the place. So one study showed a benefit of early treatment, one actually showed a harm of early treatment, and then one showed no effect. So it sort of left me scratching my head a little bit about that. And so the second outcome, the secondary outcome that I was looking at was mortality. And in this case, on the Cruz odds ratios and synthesizing those, I didn't see any significant impact of treatment timing or early treatment, whether it was defined as within 1 day all the way down to within 3 days. And then on studies that reported adjusted analyses, there were only 3. And it didn't seem like there was any effect of early treatment, whether this was defined as within 1 day or within 3 days. So to put that together, basically it seemed as though it was possible that early treatment within 1 day might improve functional outcomes, but it didn't seem like my results were really consistent when I looked at the adjusted analyses. But it didn't seem to affect mortality. And so I wasn't sure how to explain this. Is it possible that the studies didn't do a great job of, or once they were controlled for subarachnoid hemorrhage severity, that effect was minimized, and so was it possible that what I was seeing in the Cruz odds ratios was essentially influenced by the fact that earlier treatment might include sicker patients, et cetera. And so my next step was, going forward from that, could I see that there was any benefit of early treatment in a larger subarachnoid hemorrhage cohort that I could obtain from Ontario data? So I decided to go forward with my study, which was to use Ontario Stroke Registry and Health Administrative data to try to address the same question, with the hypothesis that earlier treatment would be beneficial in terms of improving outcomes, both in terms of functional status on discharge, as well as mortality at 30 days and at discharge. And so my primary data source was the Ontario Stroke Registry, and I ended up linking out to a bunch of other databases. Just a quick word about the Ontario Stroke Registry. It's composed of a number of stroke centers in Ontario that collected patient-level data on stroke between 2003 and 2013. Initially, they actually collected pretty extensive data also on hemorrhagic stroke, but after 2008 onwards, it sort of honed in on ischemic stroke. And so they were still taking in hemorrhagic stroke, including subarachnoid hemorrhage, into the database, but they weren't actually collecting extensive data on those patients. And so because of that, I ended up having to link out to all of these other studies. A lot of studies that are done on ischemic stroke with the stroke registry won't require linking out to other databases because they have very detailed, rich data for those patients. And so this is how I sort of tried to overcome that issue. And so for this study, the cohort that I included were adult patients with subarachnoid hemorrhage admitted to stroke centers that underwent either endovascular or surgical treatment. In this case, I was looking at both treatment modalities from the years where the stroke registry was active, 2003 to 2013. And sort of informed by my meta-analysis, I classified my primary exposure, which was treatment timing, into treatment within 1 day versus beyond 1 day. And the outcomes that I was looking at were modified Rankin scale on discharge, which thankfully I had from the stroke registry on subarachnoid hemorrhage patients, as well as mortality at discharge and at 30 days. And I risk adjusted for variables known to be important in influencing subarachnoid hemorrhage outcome, including demographics, subarachnoid hemorrhage severity indicators. Some of these are in italic because I'm going to go into those in a little bit more detail later, because I ran into some issues with my subarachnoid hemorrhage severity variables. Also comorbidities and certain aneurysm features that I could glean from OHIP data, essentially whether it's anterior or posterior, and whether it's larger than or smaller than 2.5 centimeters, because obviously OHIP data is not so specific for aneurysm features. And for statistical analysis, I stratified by treatment type with the understanding that patients with aneurysms who undergo coiling are different from those who undergo clipping, so it wasn't really fair to lump them all together. And so the analysis was done through multivariable logistic regression models for each of the outcomes I was concerned with, also incorporating generalized estimating equations to account for potential clustering by the person performing the procedure, by a healthcare provider, essentially. So first problem that I ran into, which was a big problem, was missing data. So in my plan to control for subarachnoid hemorrhage severity, I had hoped to use the Glasgow Coma Scale, which I thought was a mandatory variable in the Ontario Stroke Registry. It turned out it wasn't so mandatory. So if you look at the first column, that's sample size of subarachnoid hemorrhage per year, and all the fields are essentially percentage of missing data. So for the Glasgow Coma Scale, the vast majority of my data was missing for every single year. The only sort of pocket of time in which I had reasonable data collection for subarachnoid hemorrhage severity was for another score, which is called the Hunt test score, where I had less than 20% missing data from the years of 2003 to 2007. And that makes sense because after that is when the stroke registry became very tailored towards ischemic stroke, and then they sort of stopped collecting that variable altogether. So you can see that it goes very quickly up to 100% missing data. So just a quick word on subarachnoid hemorrhage grading scales, just to kind of put that into context. The Glasgow Coma Scale, which I was planning to use, is not specific for subarachnoid hemorrhage, but it's a very standard scale for neurologic impairment and level of consciousness, essentially. And so even though it's not specifically for subarachnoid hemorrhage, it's actually the major building block of the WFNS score, which is the World Federation of Neurologic Surgeons score for subarachnoid hemorrhage that is very commonly used. That score has some issues with validity and reliability as well, so there isn't really a perfect subarachnoid hemorrhage grading score to use, but it seemed to make sense to use that if I had access to it because it has been shown to correlate with outcome in subarachnoid hemorrhage, and it's shown to be fairly reliable in terms of a metric. The Hunt test scale is actually specific for subarachnoid hemorrhage. It was designed to be an index of surgical risk for these patients. But again, it's also not perfect. So there is some conflicting data regarding its ability to predict outcome, even though it has been shown in some studies to be in fact better or perform better than the Glasgow Coma Scale or the WFNS, which incorporates the Glasgow Coma Scale. And its reliability has been shown to be moderate. So again, nothing perfect, but I did need to have something because any time you're looking at an exposure outcome relationship in subarachnoid hemorrhage, you obviously need to be able to control for the severity of the disease. And so I was feeling quite discouraged that I wasn't really going to have the ability to use my whole cohort. And I came across this paper. So this is a paper that was published in Journal of Neurosurgery by a guy named Dr. Washington from the University of Washington, or Washington University, which I thought was kind of cool. And it's called the NIS Subarachnoid Hemorrhage Severity Score. And the NIS is a very large database in the United States of inpatients, essentially. And so what they did was they developed a score for subarachnoid hemorrhage severity. They developed and validated this score to be used in administrative data. And what they did was they took a bunch of ICD-9 diagnostic and procedure codes that they felt were associated with worse neurologic status. They put those in a multivariable logistic regression model to predict poor outcome, defined as modified Rankin score greater than 3, greater than or equal to 3. And they took those beta coefficients to create a scoring system. And they found that on their sort of one-way ANOVA, that sort of means of the Hunt test score rose with increasing level of the Hunt test grade, that's the top left. And there were statistically significant differences between Hunt test grade 2 and 3, 3 and 4, and 4 and 5. And they also found that for predictive ability of poor outcome defined by the modified Rankin score, it actually performed as well as the Hunt test with no statistically significant difference in area under the curve. So this seemed pretty promising if I could replicate something like that. But there are some limitations of it in the way that they designed it. So for the nationwide inpatient sample, you essentially just get a bunch of diagnostic and procedure codes associated with every admission with no idea where along the course of the admission those diagnoses or those procedures have been performed or where they're from. So there's no temporal component associated with it. So it becomes a little difficult to know if a patient had coma, for example, or if they were ventilated, if that was actually on admission and emerge, or did that actually happen maybe as a complication of the procedure. So it's hard to say for sure that this is a true predictive score, and it might actually be sort of contaminated by outcome measures. And so I felt that there was an opportunity for improvement here, where I could only, if I was doing this, I could only count codes as being present if they were present on admission, and that would give me a lot more confidence that this actually reflects their presentation of these patients and can function as a predictive score. So I decided to kind of perform a study within my cohort study, which was to externally validate the NIS score by first calculating in our cohort using the ICD-9 equivalents, or ICD-10 equivalents rather, of the ICD-9 codes that were used. and also create a modified version of the score where I only counted the codes that were present on admission, and then validate it against a subset of my cohort for which I had the Hunt test score, which was 1,459 patients, so a pretty substantial number of patients during that 5-year time frame. So to calculate the original version of the score, I basically replicated exactly what Dr. Washington's group has done. I had their beta coefficients from their paper and their formula for how they calculated the score. And I was able to find all of those diagnostic codes through the discharge abstract database for my cohort of 1,459 patients, and then calculate the score based on whether these codes were present at any time in the inpatient period. Then I calculated a modified version where I only counted those codes if they were present on admission using exactly the same inputs, essentially, and the same formula. And then I validated against the Hunt test score. And the procedure I followed for that was according to the tripod statement, which is a consensus statement based on, or that essentially describes transparent reporting of prediction models for prognosis and diagnosis. And the steps I took to do that were essentially correlating it against the Hunt test score, and then discriminative ability as well as calibration. So for correlation, there was quite strong correlation between the original version of the NIS and the modified version of the NIS in my group, in my cohort of 1,459 patients. There was moderate correlation between the both versions of the NIS and the Hunt test score. And there was moderate correlation between both versions of the NIS and discharge modified rank and scale score, but it was stronger for the original version of the NIS score, which kind of makes sense if you think about the fact that it might be contaminated a bit by outcome measures. So that sort of fits with that issue. On my results of one-way ANOVA, I found that the mean NIS score did increase by level of Hunt test grade, with statistically significant differences between Hunt test grades 2 and 3 and 3 and 4 for both the original version and the modified version. And then in terms of discriminative ability, it actually, both of the NIS score and the modified NIS score actually performed pretty well in terms of being able to discriminate with the models being made for an outcome of modified rank and score greater than or equal to 3. Their end of the curve was the lowest for the modified NIS score at 0.744, which is still pretty good. And it was statistically significantly lower in terms of performance than the original NIS as well as the Hunt test score, but it was still quite good. Where things got a little uncomfortable was calibration. So we see that the Hunt test score, which is the green line, actually is quite reasonably well calibrated in terms of the fact that the predicted probability of poor outcome by the Hunt test score matches up reasonably well with the observed probability of poor outcome. But for both the NIS score and the modified version of the NIS score, calibration is suboptimal, particularly at the lower end of likelihood of poor outcome, where it doesn't seem to be able to measure that well at all.
Did they do this in the original paper?
They didn't show calibration, no. And so I've corresponded with them a little bit about it, and they haven't really had many thoughts to add to that. But and then also for the higher end of the score, we can see that it sort of overestimates the observed probability of poor outcome. So it's obviously not perfect. And so, you know, in summary, essentially good correlation, adequate discriminative ability, but suboptimal calibration. And so going forward, what I decided to do was I was going to use the modified NIS score for disease severity adjustment in my overall cohort, which is actually 3,000, thank you, 3,000 plus patients. But in order to make sure that the results that I was getting for my treatment timing evaluation were actually reasonable or robust, to perform a sensitivity analysis in that smaller cohort where I have the Hunt test score, which is a commonly used subarachnoid hemorrhage grading score, just to make sure that what I was seeing was consistent. Does that all make sense so far? Yeah. Okay, so now we're going back to the big cohort study, which is, I began with 3,346 patients, after which I excluded those who were not treated and those who were actually coiled and clipped on the same day, because it became difficult then to classify them into one treatment category versus the other. left with 1,848 treated subjects, and of which 1,047 were coiled and 801 were clipped. So these are pretty big numbers compared to most studies that look at subarachnoid hemorrhage. That's the advantage of using ICIS data. And so for my table 1, for coiling, we're going to go through all the results for coiling first. The baseline characteristics were actually pretty well distributed between my timing groups, except for ventriculostomy, which was slightly more common in my early treatment group. But all the other demographics, other indicators of subarachnoid hemorrhage severity, comorbidities, et cetera, and aneurysm features that I did have seem to be pretty reasonably well distributed. For univariate analysis, I'm showing the analyses for the outcomes of modified Rankin score greater than or equal to 3 as poor outcome, and mortality at discharge. I've left off mortality at 30 days just to make these tables somewhat legible for you guys, but the results were exactly the same, actually, or essentially almost exactly the same, with all the same things being significant as mortality at discharge. And so what we saw here was that early treatment didn't seem to have any effect on univariate analysis for either of these outcomes. And factors that were significant were age, subarachnoid hemorrhage severity indicators, as well as comorbidities, at least for functional outcome on discharge.
What's it? You guys know this for what?
This is looking at all the baseline factors between, so all the baseline factors, including treatment timing. And I'm, yeah, and my table 2, essentially.
Between the ranking scores, not the...
I'm sorry?
It's based on ranking, modified ranking score.
Yes, for this column, and then this one is mortality at discharge. Does that make sense? And then multivariable analysis in coiled subjects show that there was no impact of early treatment defined as within 1 day. The factors that were significantly associated with outcome were similar for both functional outcome as well as mortality at discharge, and were essentially age, ventilation, ventriculostomy, and Charlson index. All the other factors that I included in the models were not found to be statistically significant, and the results were similar for 30-day mortality. Something I saw which didn't make sense to me is why is this, the Charlson index, actually being protective for mortality. And I've gone through this quite a bit with Andreas and Charles Victor, who's my the statistician on my committee, and we think it's probably a spurious result just because we're working with very large numbers of patients, because it doesn't really make sense that having a higher Charlson index would actually be beneficial for mortality. So I don't really know how to explain that. But everything else seems to sort of logically make sense. Then the results for clip subjects. Here, I was a little more concerned with the table 1 because it looks like a lot of the factors are unevenly distributed amongst early versus late treatment groups, with the early treatment group actually being sicker, with a lower GCS, a higher Hunt test score, more patients who are ventilated and undergo ventriculostomy, and even a higher modified NIS score, as well as more comorbidities in terms of hypertension and diabetes. So that's definitely, you know, in this cohort, I was certainly worried about confounding. In terms of the univariate analysis, here I did see that early treatment timing within 1 day was actually significant for both functional outcome on discharge as well as mortality at discharge, with it looking like it was actually harmful. So more of the patients who were treated early had a worse modified Rankin score and were more likely to die during admission. And again, very similar to the other analysis for coiled subjects, subarachnoid hemorrhage severity indicators as well as age and comorbidities were significant factors. So then on multivariable analysis, I found that although early treatment wasn't significantly associated with modified Rankin scale on discharge, it was significantly associated with mortality on discharge, and it actually looked to be harmful, which is not a result that I was expecting to see. And other than that, very similar results. So age, ventilation, ventriculostomy, and Charlson index also significant. And all of the other factors that were not statistically significant for coiled subjects were also not statistically significant for clip subjects. So then I performed my sensitivity analyses. The first one being that I was worried about insufficient adjustment for subarachnoid hemorrhage severity, so limited my cohort to those where I had a Hunt test score, and I found the results actually did not change. And the other bias that I was concerned about is sort of a bias that arises anytime you're looking at timing of treatment, so survivor treatment selection bias. So because I'm comparing early versus late treatment, these patients that are surviving essentially long enough to be treated late, are they inherently a healthier group of people? So in order to deal with that, I restricted my cohort to all patients that were treated only within 3 days, because I wanted to be the shortest clinically relevant time frame to look at. And all of the patients in this analysis had to survive for at least 3 days. So technically they would be eligible to receive either early or late treatment. And again, I found no significant change in my results. So in summary, it seems as though for coiling, there's no significant impact of treatment timing, whereas for clipping, it seems as though early treatment might be harmful. And so, of course, the limitations that I'm concerned about are essentially, have I adequately accounted for bias? One major issue is that my subarachnoid hemorrhage severity data is limited, and I've done my best to account for that with sensitivity analysis, which show consistency in my results. Other factors that are important for determining outcome of subarachnoid hemorrhage are hemorrhage volume. Obviously, don't have any data on that through ISIS databases. And the other thing is that I don't have any data on if rebleeding actually occurred in my group. And, you know, again, obviously don't have any data on that through ISIS databases, but that's sort of the critical piece that I'm trying to prevent through treating early. And so it's difficult, you know, to not be able to use it as an outcome measure. My consolation with that is that it's a notoriously difficult outcome measure to measure or factor to measure even in sort of prospective studies, because it's often difficult to evaluate neurological status in subarachnoid hemorrhage patients. They're intubated, et cetera. And so rebleeding events are classically missed in these patients, even prospectively. So in terms of trying to tease out why I'm seeing what I'm seeing, I certainly didn't see the benefit that I was expecting to see. One factor might be if these rebleeding events actually occur extremely early following subarachnoid hemorrhage, and there's some evidence to show they might actually occur within the first couple of hours following subarachnoid hemorrhage and then might drop off. And so in that case, if you're treating at 1 day, you might actually be missing the boat. The idea might be to treat even earlier than that. But this is essentially the earliest time frame that I can measure through ISIS data. The other factor that I wasn't expecting to see is harm, obviously. And I think the explanation that could exist behind that is that there's a lot of emerging evidence now around a sort of cascade of injury that occurs very early following subarachnoid hemorrhage, essentially triggered by very rapid increase in intracranial pressure, which results in decreased blood flow to the brain, overall ischemia to the brain, changes in the microvascular circulation and breakdown of blood-brain barrier, et cetera, which sort of is a cascade that leads to cellular injury. And potentially this effect could be more pronounced in patients who undergo surgical treatment, because as you can imagine, you're performing a craniotomy, you're playing with the intracranial pressure even more. And so that might actually exacerbate this phenomenon more than it would in endovascularly treated patients. So essentially, overall, my results support the current non-emergent management of subarachnoid hemorrhage within 72 hours, which from the endovascular perspective is essentially more of a resource question. It essentially just doesn't put additional burden on INR services that are already quite taxed with stroke management. And it also allows for patients to be transferred, procedures to be performed during regular working hours, et cetera. From the surgical perspective, though, I think the fact that I'm showing a potential for harm for early treatment, which was unexpected for me, and is not something that's, you know, typically thought of or reported in the literature, I think this is much more interesting. And I think I don't necessarily have all the explanation behind that, but I think it certainly, you know, puts it out there that this is something that should be investigated further. So just want to acknowledge my wonderful thesis supervisor, Andreas, and my fantastic committee that's been such a pleasure to work with. The fabulous people at ISIS as well, and Gabriel Wrinkle, who Carolina knows, who I've worked with quite a bit, who's also been very helpful on this. So, and thank you all for your attention, and I hope to get some feedback from you. Thanks so much. I do hope I left enough time for that, because, well, 15 minutes, it's not so bad, I guess. a lot to share.
Just wondering, in the table 1, I don't know if the score managed to capture it, but one of the things is like the WFNS is like, it's a clinical grading score. You obviously couldn't use that because it wasn't captured at the HIT-THETA or whatever.
Yeah.
That other score you used, the one from that previous study, does that include anything about ICP? Or?
No, so the NIS score?
No, the NIS score.
Yeah, it's, I can show you what so it's basically a combination of diagnostic and procedure codes. So like coma, paresis, aphasia, things like that. So there's nothing about ICP in there specifically. You might assume that these things are sort of related to it, is the idea.
The only thing, the reason I ask that is because those neurosurge patients that go right to clipping or whatever, I think usually there's a concern about the ICP at that time. So,
right, which I think might be, yeah. Yeah, no, I think that might be the missing piece, right? That might be what's explaining the harm.
Why are patients treated earlier as opposed to later? I mean, what are the patient-specific variables that drive decision-making around timing of treatment?
For now, I think it's predominantly resource dependent. So it's not considered to be something that's necessarily emergent, but it's considered to be urgent treatment. So, but it's very variable. Even so, I don't really see it from the surgical side. I see it from the interventional neuroradiologist side. And so if a patient comes in at essentially 5 p.m., they will treat that same evening. But if a patient comes in at, say, 9 p.m., they'll treat first thing in the morning. So it's very...
So there's no age, comorbidity, characteristics of subarachnoid hemorrhage, frailty. None of those factors will have a big role in determining who treated.
They have a role, but they don't have a big role because there isn't a lot of evidence around any of those things. I think there's a sort of general sense of if it's a frail patient, if it's an older patient, and if the hemorrhage is more severe in the sense of the neurological status being poor, there's a bit of a reluctance to treat. Whether that's because, there's an assumption that's going to be a bad outcome anyway, I'm not entirely sure about, but there isn't a lot of evidence behind any of it.
No, I wasn't asking about evidence, I was asking what people actually
do.
Yeah.
Some people will go ahead, some people will not.
Okay, so I wasn't asking about that either. I was asking more about timing. So...
Well, that's what I mean. Some people will come in and do it, and some people will not. And I don't, it's a very operator-specific decision.
Where is this captured? Like all these components, right?
Yeah, that's a great question. So they're captured through the discharge abstract database diagnostic codes. And so the validity is high for the first couple of diagnostic codes on that list, but it drops off. And the validity drops off, and I can't tell you offhand exactly how much it drops off for, because you have the ability to put in 25 diagnostic codes into the discharge abstract database. And so the validity does drop off after about the first 5, but that's predominantly because of missing data, not because of invalid coding. So, and it's difficult to know entirely.
We'll go and extract all of this information for someone who has a stroke, basically. I mean, they will have the most responsible diagnosis, and they will have...
Exactly.
And then you assume these things will be
underneath. So they're not 100% all the way through. The first couple are very close to 100%. Then after that, it drops off. That's a limitation as well.
I think it's very suspicious about childhood score because it's not able to predict surgical mortality, right?
Yeah, it's a bit. It'd be really interesting to just see the survival curves to try to understand when it is that people die, what it is that they die of. I presume you produced those kinds of.
I have not produced a survival curve, no.
Okay. And you were only looking at sort of short-term survival, like in-hospital survival or 30-day survival?
Yeah, because generally it's quite a precipitous event. And so death related to the subarachnoid hemorrhage occurs generally in the first weeks after the event. And I wasn't looking at a more long-term event than that.
Over the case that everybody who got clinically diagnosed, irrespective if they get surgery or not,
just to get the idea of ones who never even made the surgery. You know, if you talk about healthy survival bias or like other things, right? If you just have everyone within the same field, need the same diagnosis, maybe, right? This will also give you an idea about the overall cohort.
Right.
Even data.
In the sense of trying to explain why the Charlton looks.
Generally, when you say it's suspicious that, you know, one of the potential expressions you have is just a healthy survival bias, the ones who, you know, they're healthier than the ones who never made it. Right. You can get that easily. Say if it's actually the case, and you can just run it without having that surgery or intervention at the core tract and get everyone in the right time.
Yeah, that's a good point. Yeah.
I guess the other thing you could do is try with another comorbidity index. You know, you run it with the ECG and see if you see the same result. I mean, it's a very minor result. It's a beautiful study overall. I mean, I think it's just really lovely, but you know, that's just one anomalous result.
Yeah, and it's sort of just like an annoying thing to see that, because then it just makes you question. Yeah.
There is an ECG macro that they use commonly in diagnosis, so you could just rerun your exact same analysis just using ECGs to substitute for the Charlton and see if that makes a difference.
Yeah. Super, I will try that. Yeah, it's very quick to do.
Severity is the most important thing you want to justify. When you have something you're suspicious, you want to be confident, right? With that.
Exactly, yeah. Well, that's really helpful. I will try to look at that as well, at least for that part of the bias. There's not much I can do about the subarachnoid hemorrhage severity, but
yeah, so that even, sorry, I'm just going to stop talking, but even within like the 30 days, I think it'd be really interesting to see exactly when it is that people die.
Yeah.
You know, are these deaths that all happen at day 1, day 2, day 3? Just, I mean, I'm sure your clinical readers would also be kind of interested to see when it is that people are dying.
Mm-hmm.
You know, with a common index date, not the date of the procedure, obviously, but the date of the hemorrhage.
Right.
And then to try to understand the different patterns of mortality, and then longer term outcomes. The reason you're equipping these people and coiling them is to prevent bad things in the future too. So even if you see a short-term mortality difference, if there's a tail of mortality curve that favors one or the other, that's also policy relevant.
Yeah, that's true. Yeah, that's true. I could look at mortality at 6 months, things that I won't have access to modified Rankin score, but it's still worthwhile to look at mortality longer term. I guess that's it then. Thank you all very much. I really appreciated that. Yeah, there's a lot of politics, but and again, it's very person dependent. Some surgeons are more aggressive than others.
Because you wonder whether that also
makes a difference.
Yeah, when he's down there.
selection or
yeah, but this,
I think you're right. I think having I think based on this with hemorrhage, having a clinic for me within like first, it's not minor, right?
Yeah, it's a big thing.
So it's a big thing, and you'll have everything there. So I can imagine why, but I think it's just common because if it's early mortality is like closer to surgery, you could more it's like a direct almost direct result of surgery, as opposed to long-term mortality. And I think that would be really interesting.
Yeah. No, that's very true.
So related to that, I was thinking like what kind of a variable you could find to like reflect that. I don't know, like it seems very like hard to like find variables to, but if you could track something for meds given, is there any database that looks at like people get like hypertonic saline or
In hospital, no.
no, it has to be that
yeah.
discharge ODS.
Yeah.
I think they're always about it. It's impossible to get.
It's hard to get. It's frustrating because you're like, I want that one thing, and then thank you.
Aneurysm size always is on the back, like but then you'll never like. It's impossible.
I have greater than or less than 2.5.
That's it, and then
like it's those like so how much they actually code this. They go the most important ones, and then the ones that you care, but not that you are doing with someone who's just doing data abstraction for any condition, right? You will not get.
Well, because I guess there isn't, and there is no payment necessarily for that, right? For more diagnoses or something like that. So
very interesting, really cool. That would be. I think it's a very relevant finding.
I think it's 3 papers. Like I don't know, I posted 2. Just 3.
3. Yeah.
Your second one is the
external validation one.
Yeah, because it's one published saying this, how one compares with the other one. including with the meeting values.
Yeah. That's a big undertaking on its
It has
own.
to be 3 papers, right? So the thesis
It has to be
so,
3.
yeah.
But you have them. You have the.
No.
You just put one, you just present one in between.
It kind of flows with it, right? Like, because
We are doing a very, very small study, like with someone else sitting here, looking at aortic dissection, and like it's a very small sample size, in like 200 patients. Rather than we are looking male versus female, we wanted like a surgical, adjustment score. We found one, we tried to measure it, and then the ultimate question is, can even I use this score that was developed, let's say, in Germany, in this population, right? So you have to build it. I mean, we have to, and then when you're presenting all this calibration, discrimination, we're able to get each other, because like an hour ago, we we're just talking about the same, for this like specific small patient population, is still like rare, right? And not everybody will make the surgery.
Yeah.
Like, exactly the same situation.
Yeah, that validation thing caused me the most sleepless nights.
But you have to do, and until it gives you the, anxiety and, because I was suspicious with the child, so why like that? And it's not a big sample. You have a relatively small sample through any IHS studies, right?
That's true. Yeah.
So,
for me, it seems like a big sample because it's subarachnoid hemorrhage, but
I know, but
it's not like 12,000 people.
For IHS, like most of the cardiologists.
I know, they're like thousands. Yeah.
And but I just two small comments on slide that I'm here.
Oh, sure.
Alex. So I just for you to go back to your schematic review. Peak all the way. Which is quick. I also have the peak. Yep. So your intervention is basically endovascular coiling early versus endovascular coiling late, right?
Yes. And then what is my comparison then?
Endovascular early, endovascular late.
I see what you're saying.
Define. And then you can openly say, I'm not sure how they define all C when because you have 1-3 days like differently.
Okay.
You can play with it, say I'm not sure, because you have to say early defined as this, late defined as this, but because you don't have it, you can say early as this, and then I teach what I can. Oh yeah, that's really helpful. And then the other one, if you go to, remember I had a question about the ranking one. You used your table 2, which I get right, but I have another question there. Not question.
I see. Yeah, I felt like I didn't properly answer your question.
No, I know why. I know why it was right, but it was me. So okay, so go back to first one back.
Yeah.
So with your table 1, where you say my treatment, and then you compare your groups, right? So your table 2, basically, you're looking for confounding. That's why you have your outcomes, and then everything significant here will go to your adjusted analysis, right? And I think why I asked, because I saw this here, and we usually, I'm not used to see the treatment I'm looking here. Anyway, but that's why I asked the question.
That's my key predictor.
That's your key,
variable of interest, which is why it's so
that's why I asked the question. The rest everything is right. So, but
is this right or is it wrong then?
No, it's right. It's right. It's basically also if anything you find significant on the other one, you go back on this one, and then on the next one should go to, because you're confounding, right? You have the treatment, you have the outcome.
This is associated with exposure, this is associated with outcome.
Yeah,
exactly.
I guess I didn't get first one, but then I got it. So it's just, it's like 499. Because we are dealing with neurostatics through IHS, we are trying to do the propensity score matching, and the perfect match, everything is perfect, but there is a residual confounding which we couldn't find. Because your Charleston, the fact that you have a difference in Charleston could be because there is some factor you need to adjust but you didn't adjust, right? And it could be your severities. Exactly, irrespective you use these or use propensity score, you are going to face with the same issue. Because there's something you don't adjust. It's not a randomized trial, it's observational study, and then you cannot put unlimited number of variables because your sample size is how much, 500?
I can put a lot of variables, but
not for mortality, maybe because
because it is less.
How many
105? I can put 10.
You can put 10. But still, I think for some of them, your confidence intervals. No, it wasn't here. There was one with big confidence, or maybe it was meta-analysis. Yeah, your confidence intervals are not that bad. Yeah, it's a bit. I mean, you're looking at ranking. Can you adjust for baseline ranking? They come with rankings, right?
They don't actually come with a ranking. They don't test that on intake. What they're supposed to test on intake
because
is the
they can do it, right? Then
Yeah.
Any severity, and then that one you don't have it, right? You said this is, did you just
It was,
put it?
yeah, I did, and it was not significant.
About, is it here?
No, it's in here, but because to make the table.
Oh, no,
viewable,
I'm not, in the I'm asking, so you have it.
Yeah.
But some of them don't have it, right? You said this is it missing too much or not?
No, this is the one I was able to get for everybody. It's the,
So everybody had it.
yeah, it's the Hun test score that I don't have, the good one, the better quality or more valid score that I don't have in everybody. But then instead of using this in my sensitivity analysis, I use the Hun test score.
And you got the same. I mean, you tried, that's why you poked from every side.
Exactly.
See how I
Exactly.
can explain.
Yeah.
That's, I think, the beauty of the small sample size, and you don't know what to do with all. I mean, not the beauty.
The beauty. Yeah. The pain in the butt is what you really mean.
Yeah.
Anyway,
Anyways,
thank
I
you.
mean,
This is super. Can I get your email? Because
oh, sure.
I didn't even bring a pen and paper, but
I mean, it's my first name, last name, 3 of T.
but it's super nice to get this kind of feedback, and
It's Sinai.Sapna, and I can go on the .ca.
Armenian name.
Yes, it is.
How do I pronounce your first name again?
Lucine.
Lucine.
But you know someone Armenian that
I know a lot of
there's
Armenians.
a radiologist Armenian. Gevorg?
Gabor Natsakarian, right?
Yeah. And my son goes to the same school as his son.
Oh, wow.
Yeah, and they know the
Oh, he's so nice.
He's very nice, like, yeah.
I just want to make sure that I spelled everything right. At UHN.ca.
No, you can also.
You Toronto.
I don't even know where's my age. I can check my email.
It's mail.utoronto.ca?
No, I'm old generation.
The old generation. Well, you look like young generation.
Anyway, good luck.
Thank you very much. I really appreciate that feedback. Super helpful because sometimes when you're like, I'm like, why haven't I done survival curves to see that? But when you're so in it, it's like hard to even have a perspective.
It's not all, the study is one I was saying with the professors co-matching everything. So we have 40-something variables.
Yeah.
Huge sample size of all COPD patients. Everything is matched perfectly.
Yeah.
They are looking for effect of pharmacist-led medication reviews. So pharmacist talks to a patient half an hour. So if you think about it, like with the COPD patients, chronic, how much effect in mortality you are expecting over 3 years or 6 months? Any?
No, I don't know anything about that.
So, no.
Yeah,
what I'm asking,
yeah.
our primary outcome is adherence. We want to adhere to, but we say, to make sure we don't have residual confounding, let's look at mortality.
Yeah.
And then we saw 10% mortality decrease in 6 months, which means there's residual confounding.
Yeah.
With 40 variables, we cannot do anything.
Wow.
And Mary was part of that. So, and then we are trying to write a paper saying, in some situations, that's where you are. That's where you are. That's where you are. I think it was your announcement then.
Oh, yeah.
Anyways, you can send me this out.
Yeah, good luck. Thank you so much. Oh, good. Are you getting back to me? Yeah, that's fine. Nice meeting you. Nice meeting you too. Okay. Take care of you. Yeah, no, if I come across that, up until now, it's all really kind of like what have you done so far, and how it has impacted you, and all of that. So,
It's a real reason. Talk about a challenge. I just wasn't sure if that actually was going to ask her. She thought about it. So.
because it's something that you should because is it related to the, like to me it's not related to the brand or
But if they think too late, it somehow highlighted. That's the question.
Yes, I think one of the questions.
Yeah. Yeah.
And so, okay. One of the responsibilities. Yeah.
Check with them.
Yeah.
And then I can mark it accordingly and say, yes.
Yeah.
We can write a paragraph of what the challenge is, if that's what they want to do.
Yes, but I mean, the thing is, like, we're like I've been emailing Tom, like, we could also say it's been a challenge, but, we are trying to work to resolve it. Maybe that would be.
Yeah. So again, if they come back saying yes, let's just do that, then I'll read a paragraph from you and say, like, a summary of what we want to say there.
Yeah.
Okay.
Ice cream ready?
Yeah.
Or on the desktop?
Great. Thank you very much. I was just about to
Just send an email to
email to
everybody.
everybody, yes.